Welcome everyone to the Apothecary Tales, the basics of pharmacology. Today we're going to talk about the adrenal hormones that is being produced by the adrenal gland. The adrenal gland consists of the cortex and the medulla. The medulla secretes the catecholamines, whereas the cortex secretes two types of corticosteroids and the adrenal androgens. The adrenal cortex has three zones, and each zone synthesizes a different type of steroid hormone from the cholesterol. So the different zones are the outer zona glomerulosa, then we have got the middle zona fasciculata, then inner zona reticularis. So the outer zona glomerulosa produces the mineralocorticoids, for example the aldosterone, that are responsible for regulating the salt and water metabolism. Production of the aldosterone is regulated primarily by the renin-angiotensin system. Now the middle zona fasciculata synthesizes the glucocorticoids, for example cortisol, that are involved with metabolism and response to the stress. The inner zona reticularis secretes the adrenal androgens. Secretion by the two inner zones and to a lesser extent the outer zone is controlled by the pituitary adrenocorticotropic hormone, that is the ACTH hormone, which is being released in response to the hypothalamic corticotropin releasing hormone. Glucocorticoid serves as the feedback inhibitors of these ACTH and CRH secretion. So here we're going to talk mainly about the corticosteroids. The corticosteroids bind to specific intracellular cytoplasmic receptors in the target tissues. The glucocorticoid receptors are widely distributed throughout the body, whereas the mineralocorticoid receptors are confined mainly to the excretory organs such as the kidney, colon, salivary glands and the sweat glands. Both types of receptors are actually found common in the brain. After dimerizing, the receptor hormone complex recruits the coactivator or the co-repressor proteins and translocates into the nucleus, where it attaches to the gene promoter elements. There it acts as a transcription factor to turn the genes on when complexed with the coactivators, or gets off when complexed with the co-repressors depending on the tissue. However, other glucocorticoid effects are immediate, such as the interaction with the catecholamines to mediate relaxation of bronchial musculature. This section we're going to talk mainly about the normal actions and the therapeutic uses of the corticosteroids. First we're going to talk about the glucocorticoids. Cortisol is the principal human glucocorticoid. Normally, its production is diurnal, that means with a peak early in the morning followed by a decline and then a secondary smaller peak in the late afternoon. Factors such as stress and levels of the circulating steroid will influence its secretion. The effects of cortisol are many and diverse. So in general, what do? So first they promote the normal intermediary metabolism. That is, these glucocorticoids would favor the gluconeogenesis, that is synthesis of glucose, through increasing the amino acid uptake by the liver and kidney and elevating activities of gluconeogenic enzymes. They stimulate the protein catabolism except in the liver and lipolysis, thereby providing the building blocks and the energy required for the glucose synthesis. And it is important to keep in mind, if there is a glucocorticoid insufficiency, it would lead to hypoglycemia. Why? Because we have already mentioned glucocorticoids are involved in the glucose synthesis. So when there is an insufficient amount of glucocorticoids, much amount of the glucose is not being, or sufficient amount of the glucose is not being produced. As a result, it leads to hypoglycemia. For example, the circumstances where glucocorticoid insufficiency occurs is during the stressful periods or fasting. Second action is that it is responsible for increasing the resistance to stress. So we have already mentioned the glucocorticoids increases the plasma glucose level. This would thereby provide the body with energy to combat the stress caused by the trauma, fright, infection, bleeding or debilitating disease. The third mechanism is that it is mainly involved in altering the blood cell levels in plasma. Glucocorticoids will cause a decrease in eosinophils, basophils, monocytes and lymphocytes by redistributing them from the circulation to the lymphoid tissue. Whereas it will also increase the hemoglobin, erythrocytes, platelets and polymorphonuclear leukocytes. Next, it has also got an anti-inflammatory action. The most important therapeutic properties of these glucocorticoids are their potent anti-inflammatory and immunosuppressive activities. These therapeutic effects of the glucocorticoids are the result of a number of actions. The lowering of circulating lymphocytes is known to play a very important role. In addition, these agents would inhibit the ability of leukocytes and macrophages to respond to the mitogens and antigens. These glucocorticoids also decrease the production and release of the pro-inflammatory cytokines. They inhibit the phospholipase A2, which blocks the release of arachidonic acid, that is a precursor of the prostaglandins and leukotrienes, from the membrane-bound phospholipid. The decreased production of the prostaglandins and leukotrienes is believed to be central to the anti-inflammatory action. Lastly, these agents would influence the inflammatory response by stabilizing the muscle and basophil membranes, resulting in decreased histamine release. The other systems which the glucocorticoids would affect is, it would lead to high levels of these glucocorticoids would serve as the feedback inhibitors of the ACTH production and affect the endocrine system by suppressing further synthesis of the glucocorticoids and thyroid stimulating hormone. In addition, the adequate cortisol levels are essential for the normal glomerular filtration. So, the effects of the corticosteroids and other systems are more associated with the adverse effects of the hormone. Next, we're going to talk about the mineralocorticoids. Mineralocorticoids help to control the fluid status and concentration of electrolytes, especially the sodium and potassium. Aldosterone acts on the distal tubules and collecting ducts in the kidney, causing reabsorption of sodium, bicarbonate and water. Conversely, the aldosterone decreases the reabsorption of potassium, with which the H+ ions is then lost in the urine. Enhancement of sodium reabsorption by aldosterone also occurs in the gastrointestinal mucosa and in sweat and salivary glands. Very important thing to keep in mind is that elevated aldosterone levels may cause the alkalosis and hypokalemia, retention of sodium and water, and increased blood volume and blood pressure. Hyperaldosteronism is usually treated with the spironolactone. The target cells for the aldosterone contain the mineralocorticoid receptors that interact with the hormone in a manner analogous to that of the glucocorticoid receptors. Now, what are the therapeutic uses of the corticosteroids? So, there are several semisynthetic derivatives of the corticosteroids that are available, and these agents usually vary in their anti-inflammatory potency, mineralocorticoid activity and duration of action. Corticosteroids are used in replacement therapy and in the treatment of severe allergic reactions, asthma, rheumatoid arthritis, other inflammatory disorders and some cancers. So first, it is used as a replacement therapy for the primary adrenocortical insufficiency, that is Addison's disease. So Addison disease is caused by adrenal cortex dysfunction, which is usually diagnosed by the lack of response to the ACTH administration. So hydrocortisone, which is identical to the natural cortisol, is usually given to correct the deficiency, and failure to do so results in death. The dosage of hydrocortisone is usually divided so that 2/3 of the daily dose is given in the morning and 1/3 is given in the afternoon. So the purpose of this regimen, or the main goal of this regimen, is to mimic the normal diurnal variation in the cortisol level. So if you remember, we had already mentioned about the diurnal secretion of the corticosteroids, that is higher peak secreted in the early morning, then a second peak in the later afternoon. In order to mimic such a normal diurnal variation in the cortisol levels, such a regimen has been adopted. Then administration of fludrocortisone, a potent synthetic mineralocorticoid with some glucocorticoid activity, may also be necessary to supplement the mineralocorticoid deficiency. Next, it is used in the replacement therapy for the secondary or tertiary adrenocortical insufficiency. So these disorders are usually caused by a defect in the CRH production by the hypothalamus or in the ACTH production by the pituitary. So remember, under these conditions, the synthesis of the mineralocorticoids in the adrenal cortex is less impaired than that of the glucocorticoids. So we're trying to give the hydrocortisone for these deficiencies. Next, it is used in the diagnosis of the Cushing syndrome. So Cushing syndrome is usually caused by the hypersecretion of the glucocorticoids, which is also termed as the hypercortisolism, that results from excessive release of the ACTH by the anterior pituitary or an adrenal tumor. So remember, the chronic treatment with high doses of glucocorticoids is a frequent cause of the iatrogenic Cushing syndrome. So the cortisol levels, such as in case of urine, plasma and in saliva, and in the dexamethasone suppression test are used to diagnose the Cushing syndrome. The synthetic glucocorticoid dexamethasone suppresses the cortisol release in normal individuals but not those with the Cushing syndrome. Next, it is used in the replacement therapy for the congenital adrenal hyperplasia. So this congenital adrenal hyperplasia is a group of diseases that is resulting from an enzyme defect in the synthesis of one or more of the adrenal steroid hormones. The congenital adrenal hyperplasia may lead to virilization in females due to the overproduction of the adrenal androgens. Treatment of such condition requires the administration of sufficient corticosteroids to normalize the hormone levels by suppressing the release of the CRH and ACTH. This decreases the production of the adrenal androgens, and the choice of replacement hormone depends mainly on the specific enzyme defect. Next, it is used for the relief of inflammatory symptoms. Corticosteroids significantly reduce the manifestations of inflammation associated with the rheumatoid arthritis and inflammatory skin conditions including redness, swelling, heat and tenderness that may be present at the site of inflammation. These agents are also important for maintenance of symptom control in persistent asthma as well as management of asthma exacerbations and active inflammatory bowel disease. Whereas in non-inflammatory disorders such as osteoarthritis, intra-articular corticosteroids may be used for treatment of a disease flare. Corticosteroids are not curative in these disorders. Next is for the treatment of allergies. Corticosteroids are beneficial in the treatment of allergic rhinitis as well as drug, serum and transfusion allergic reactions. In the treatment of allergic rhinitis and asthma, fluticasone and others are applied topically to the respiratory tract through inhalation from a meter-dose dispenser. So the advantage of this is that this would minimize the systemic effects and allows the patient to reduce or eliminate the use of oral corticosteroids. Next, it is used for the acceleration of lung maturation. Respiratory distress syndrome is a problem that has been found in the premature infants. Fetal cortisol is usually the regulator of the lung maturation. Consequently, a regimen of betamethasone or dexamethasone is usually administered intramuscularly to the mother within the 48 hours preceding premature delivery, which would accelerate the lung maturation in the fetus. Next, we're moving on to the pharmacokinetics of these corticosteroids. Orally administered corticosteroid preparations are readily absorbed. Selected compounds can also be administered intravenously, intramuscularly, intra-articularly, for example into the arthritic joints, or it can be given topically or via inhalation or intranasal delivery. All topical and inhaled glucocorticoids are absorbed to some extent and therefore have the potential to cause the hypothalamic pituitary adrenal axis suppression. So this HPA axis suppression is resulting in the reduced cortisol response, which may cause an impaired stress response and an inadequate host defense against infection, which remain a cause of morbidity and death. Greater than 90% of the absorbed glucocorticoids are bound to the plasma proteins, mostly corticosteroid binding globulin or albumin. Corticosteroids are metabolized by the liver, microsomal oxidizing enzymes. The metabolites are conjugated to glucuronic acid or sulfate, and the products are further excreted by the kidney. Remember, the half-life of corticosteroids may increase substantially in hepatic dysfunction. Prednisone is preferred in pregnancy because it minimizes the steroid effects on the fetus. It is a prodrug that is not converted to the active compound prednisolone in the fetal liver. Any prednisolone formed in the mother is biotransformed to prednisone by the placental enzymes. So there are many factors that has to be considered in determining the dosage of corticosteroids, including the glucocorticoid versus mineralocorticoid activity, duration of action, type of preparation, and the time of day when the drug is administered. When large doses of the hormone are required for more than 2 weeks, suppression of the HPA axis occurs. Alternate day administration of the corticosteroid may prevent this adverse effect by allowing the HPA axis to recover or function on the days the hormone is not taken. Now coming to the adverse effect profile of these drugs or these hormones, the adverse effects are often dose related. For example, in patients with rheumatoid arthritis, the daily dose of prednisone was the strongest predictor of the occurrence of adverse effects. Osteoporosis is the most common adverse effect due to the ability of glucocorticoids to suppress intestinal calcium absorption and inhibit bone formation and decrease sex hormone synthesis. Patients are advised to take calcium and vitamin D supplements. Bisphosphonates may also be useful in the treatment of glucocorticoid-induced osteoporosis. And to note that increased appetite is not necessarily an adverse effect. In fact, it is one of the reasons for the use of prednisone in cancer chemotherapy. And these are the other adverse drug reactions. The classic Cushing-like syndrome, redistribution of body fat, puffy face, hirsutism, and increased appetite is observed in excess corticosteroid replacement. Cataracts may also occur with long-term corticosteroid therapy. Hyperglycemia may develop and lead to diabetes mellitus because we have already mentioned the glucocorticoids are involved in the gluconeogenesis, which is responsible for the increased glucose synthesis. So diabetic patients should monitor the blood glucose and adjust the medications accordingly if taking the corticosteroids. Co-administration of medications that induce or inhibit the hepatic mixed function oxidases may require the adjustment of the glucocorticoid dose. Topical therapy can also cause skin atrophy, ecchymosis, and purple stripe. Now, what about discontinuation? A sudden discontinuation of these drugs can be a serious problem if the patient has suppression of the HPA axis. And in this case, abrupt removal of corticosteroids causes acute adrenal insufficiency that can be fatal. The risk, coupled with the possibility that withdrawal might cause an exacerbation of the disease, means that the dose must be tapered slowly according to individual tolerance. The patient must be monitored carefully. Now we're going to talk about the inhibitors of the adrenocorticoid biosynthesis or function. So several substances have proven to be useful as inhibitors of the synthesis or function of adrenal steroids. They are the Ketoconazole, Spironolactone, and Eplerenone. So first, the Ketoconazole is an antifungal agent that strongly inhibits all the gonadal and adrenal steroid hormone synthesis. It is used in the treatment of patients with Cushing syndrome. The spironolactone, which is an antihypertensive drug, usually competes for the mineralocorticoid receptor and thus inhibits sodium reabsorption in the kidney. It can also antagonize aldosterone and testosterone synthesis. It is effective for hyperaldosteronism and is used along with other standard therapies for the treatment of heart failure with reduced ejection fraction. Spironolactone is also useful in the treatment of hirsutism in women, probably due to interference at the androgen receptor of the hair follicle. The adverse effects include the hyperkalemia, gynecomastia, menstrual irregularities, and skin rashes. The last inhibitor could be the Eplerenone, specifically that binds to the mineralocorticoid receptor where it acts as an aldosterone antagonist. This specificity avoids the side effect of gynecomastia that is associated with the use of spironolactone. It is approved for the treatment of hypertension and also for the heart failure with reduced ejection fraction. So that is all about the corticosteroids. So let's just summarize what we have learned in this video. So we have learned about the adrenal gland in very brief, then adrenal cortex and medulla. Then we have talked about glucocorticoids, its synthesis and release, mechanism of action, the pharmacokinetics, the adverse drug reactions, and also that of the mineralocorticoids. So if you've got any suggestions, comments or doubts, please do mail in us. Thank you.